In Malta, I have a small farmhouse where I live, and it's surrounded by fields. And the soil in my fields is essential for me to grow my vegetables and my roses and my freesia, my irises successfully. But when Penny, my dog, brings the same soil onto my carpet, then that's a disaster. So the context of a few meters makes soil essential in my fields, but soil on my carpet a disaster. So that's context. It's the same soil, but because it's in a different place, it's completely different. And it's the same with global solutions, the same with international solutions. Unless we know the exact context of where we're working or where we're trying to apply that solution, then it's extremely difficult to address a global situation globally. So we need to go down to the detail. I'll give you an example of what's happening now in the European Union with our vaccine contract, with our COVID vaccine contracts, right? So at the beginning of the pandemic, Malta pushed for, and we eventually got there, we pushed for all 27 European Union countries, European Union member states, to negotiate and procure vaccines jointly, which meant that citizens across the European Union got the vaccines at the same time, and we could start tackling COVID together. And the way it worked was that countries got the amount of vaccines according to a per capita distribution. So the European Union has roughly 500 million people. Malta, with a population of 500,000, got 0.1% of the vaccines. Poland, with a population of 40 million, got 8% of the vaccine. And that sounds fantastic. But what we failed to do is we failed to look at the detail of local context. So Malta traditionally has a very high rate of vaccine acceptance. Poland does not. So Malta, we used up 98% of our vaccines. Poland used up barely 50% of the vaccines. So now Poland and countries in the East with similar low vaccine uptake have way, way more vaccines than they need. And they are now trying to rescind, or at the very least, re-engineer or renegotiate the vaccine contracts. And this is happening now because we didn't look at the local context 2 years ago. Vaccine supply is, of course, not the only issue that we have to look at, because vaccines, it's essential that you get vaccines, but then vaccines need to go into the arms of people. At one point, Malta was working with some countries in Africa to distribute some of our vaccines, to pass on some of our vaccines to African countries. With Rwanda, it worked excellently. And this was because the Rwandan side of the equation was very well organized, extremely efficient, and vaccines came from Malta to Rwanda and to the citizens within a few days. With another African country, which will remain unmentioned, we had great difficulty because hundreds of thousands of our vaccines reached the airport, but then there were major difficulties in distribution to citizens within that country. So the local context made a big difference. The same disease, COVID, the same treatment, the vaccine, local context made an extremely different outcome to where we're looking. So this is what it's all about. And the Commonwealth, and especially the Commonwealth Business Forum, is in a unique position to be able to provide local context to business communities. So anybody any business community who's serious about going global, or at least going international, needs to know this local context. If you look at regulation across the globe for digital solutions, it varies immensely. And unless you know the local regulations, unless you know the local contacts, supplying a common digital solution across countries will lead to failure. The same will happen now with post-pandemic, and especially with the rising international tensions that we are going through. Unless you know the supply chain logistics of each country, of each city, then you are setting yourself up to fail. And the Commonwealth and the Commonwealth Business Forum can do this, can help you out with this, can help businesses out with this, because the Commonwealth is a unique organization. It is one of the few organizations which represents or which has member states from across the four corners of the world. And here in this business forum, we can give that context. Of course, the pandemic isn't over yet, but it's not the only global healthcare problem that we are facing. So we're talking about antimicrobial resistance. We're talking about problems with climate change. We're talking about food shortages and food security, both caused by weather and by war. We're talking about lack of healthcare workforce. All these are now global problems which need global solutions. But unless we apply the local context, then a whole global solution will fail. And this is where the Commonwealth, and this is where especially the Business Forum can help out. The Commonwealth Business Forum can tell us which is the field and which is the carpet. So our soil will fall into the right context. And additionally, and to conclude, we have so much that we can all learn from each other. So authorities, Commonwealth member states, businesses, companies, public and private, so much we can all learn, so many best practices from across the Commonwealth that we can apply to each other's health services. And this is why I keep coming to the Commonwealth Business Forum year after year, or every 2 years, except now because of the pandemic it's been 4 years. Because the Commonwealth Business Forum offers such a fantastic opportunity for networking, such a fantastic opportunity to get in touch with the four corners of the world, that coming here is essential. I wish you well for the next few days, and I wish that you make good use of this opportunity that the Commonwealth Business Forum is giving us for networking, because your businesses, and even more so, the citizens of all our countries, will be the better for it. Thank you very much.
Thank you very much, Right Honourable Deputy Prime Minister Chris Fearn. I would like to go to the next part of the program. Like I say, just to briefly orient you, the session will run in two parts. The first part will consist of a panel conversation on addressing the global health equity gap, and the second will be a fireside chat focused on innovating for vaccine equity. I would like to welcome for opening remarks Frank Hester, OBE, who is also the CEO of TPP. A warm welcome to him.
Thank you. Well, as the lady said, my name is Frank. I work in software, medical software specifically, and I'm from the UK. And I want to talk briefly today about health technology and data. I got introduced to technology when I was 14 years old. I became a computer programmer. I was fascinated with it. I'm fascinated with the power of computers. I went on to use computers in my parents' business. They had a small family business. And then after that, I went to work for one of the largest retail banks in the UK. And both these companies, even though our parents' company was small and the other one was very large, both had a tremendous administrative burden. And with that came mistakes. And what I was able to see was the power of technology to reduce that administrative burden and reduce the number of mistakes that were made. For my mother, it gave her life back. She got a day off per week. She didn't have to work evenings anymore. And she became richer. For the bank, they became more profitable. it was a better customer experience. And the bank became more efficient. Then 25 years ago, I turned my attention to healthcare. I could see that there was a massive administrative burden there, and I felt technology could help. And I can also see, unfortunately, that mistakes were made. In my own family, my dad was given the wrong treatment at the end of his life in A&E. My mother was given the wrong drugs while she was in hospital, and she nearly died. And my sister managed to have her appendix taken out 3 times in our local hospital. All these mistakes were made by professional doctors with good hearts who were doing the right thing. But all of those doctors had the wrong information in front of them. It wasn't their fault. And I think part of our job is to make sure doctors do have the right information in front of them. And that gives a better patient experience, obviously. So what I've seen over those 25 years, the power of tech and data, is to expand capacity, give people back their time. I'm delighted that so many doctors and nurses have said to me, they've said, thank you, Frank. You know, this has made a difference to me. And healthcare across the world, as we well know, is overburdened and expensive. And if we can give doctors and nurses back time, then surely we should. The technology can underpin better, safer care for people and their families. And it also allows the citizen to trust the doctors and nurses more. So my priority for tech in the Commonwealth, I firmly believe from my own experience, from my life, that we need national EMR platforms across the Commonwealth, from Africa to Asia and the Caribbean. We need reliable, fast data. We need solutions that work on mobile devices in low infrastructure regions. We need to record the big data so we can have the artificial intelligence. Then, more doctors and nurses can focus on patient care. We can set up systems where expert consultants can look after millions of patients across regions. We can expand access and capacity. This helps democratize healthcare right across the Commonwealth. And I believe that AI will put the collective best healthcare across the Commonwealth in the hands of every citizen in every country, improving quality, reducing inequalities, and building trust. And I've seen this work in my own country back in the UK. We look after 50 million patients. The AI we've built, it's startling to see. I think for everybody when they first build some AI, it's startling. But we're doing early detection of cancer. And we started with ovarian cancer. And as we all know, for every woman, the earlier you detect that cancer, the better the survival chances are. This sort of thing should be right across the Commonwealth. And I want to make this subtle point. We all saw the power of tech during the pandemic. And I don't want us to build COVID platforms. I don't want us to build HIV platforms. I don't want us to build diabetic platforms. You build a national EMR, and all that just comes with it. And if you're really going to do AI, you can't just build a diabetes platform, because the AI needs to look all around the medical record, and it's in those unexpected places that you'll find its strength. So how will we achieve this? Well, the first step is through events like this, through talking about it, setting it as a goal. My company has a stand here, and delightfully, lots of people from lots of countries across the Commonwealth are coming to us and are talking about a national EMR for their country. We need to bring together governments, agencies and industries. We need to all work in partnership. Us techies, our job is to provide you, at massive scale, very low infrastructure requirements, systems that are financially viable. I want to smash the myth that healthcare technology needs to be expensive. I think some companies across the world have done a marvelous job of preserving that myth. In almost every other industry, technology has brought the price of things down. But healthcare technology has kept the price up. We need to smash that myth. And we need to be giving world-class, best healthcare software right across the Commonwealth. So finally, our job is to give you the tools to keep improving your health and your care priorities, increase your HAQ indices, and build strong healthcare systems together. Thank you.
Another round of applause for Frank Hester. Thank you for those very insightful and quite candid remarks regarding building tech-based platforms that are holistic in nature and don't work as silos, especially in a post-COVID world. I'd like to go to the next part of the program, which is very stimulating conversations, I'm very sure, based on panel discussions. And with that, I'd like to welcome my good friend and excellent moderator, Georgine Dirango, to take over from here. Thank you.
Good afternoon. Good afternoon. See, now, because of how you responded, we have to make sure we have the energy for this particular session. If you could kindly just stand up. It's not me, it's you. Please just stretch, high five two people or fist bump them. Stretch, stretch, stretch. We'll keep stretching until we get the right answer. Good afternoon. Oh, there we go. See, that wasn't that hard, was it? All right, let's kindly have our seats. Perfect. Thank you very much for all of you, to all of you for joining us. We really appreciate your time. What's going to happen is very simple. First, we'll have a panel discussion on bridging the global health equity gap. Should be about 40 minutes, so 20 minutes of conversation, and then we'll give you the microphone where you can ask 5 to 8 questions. So we should have about 40 minutes of the first conversation, and then we'll have a presentation as we transition and the seats are changed. Then we'll get into another panel discussion. As you'll notice, 20 minutes goes very quickly, so we're going to try and get as much information as possible from the fantastic panelists that will come on stage. So let's get things going. We start off with bridging the global health equity gap conversation. First up, we've just heard him speak. Frank Hester, CEO of TPP from the UK, kindly join us on stage. A phenomenal person in the industry, Professor Sinead Fiseha, Director of International Programs from the Susan Buffett Foundation, Ethiopia. Kindly join us on stage. Gregory Roxon, CEO of M-Pharma, Ghana. And our good friend, Dr. Sangudele, the CEO of Africa Health Holdings. Kindly join us on stage as well. Thank you. Are we ready? Yeah? Okay. Last week, we were discussing with a friend of mine, a friend who also happens to be in the VC space, and they said something along the lines of, COVID should have brought all of us into a class and done a master class on scaling and on scaling, right? Because COVID is the only one that has managed to do it across the world equitably. Now, not to remove the seriousness of what the pandemic was, But that's what most innovations around this time are suffering with, scaling and innovation. And there's something that was said yesterday when we had a panel with Sangu. One of the people asked, innovation in Kenya doesn't necessarily have to be innovation in Rwanda. Might have been something that did not work in Kenya, but works in a different country. So we need to also separate those. Within the context of inequalities around the world, and I know we'll speak about it even from an Ethiopian perspective, and I've seen also during the last few days you've spoken about it. Inequality, when we discuss it in such a room, we're talking about maybe a company that works, or like an issue that is in Rwanda versus, or vis-a-vis an issue that is in San Francisco, or a solution in Ethiopia vis-a-vis something in London. But when we come to such a forum, we need to make it very clear when we're bringing to the table and having conversation. We say some of the inequalities we have are very inherent and very deep. So let's say healthcare in Kenya and healthcare in Rwanda are very different, right? And that's close. It's nothing to do with another continent, so that's very close. In the capital city, in Rwanda, and outside the capital city, inequalities. Women, men, inequalities. Women in the rural area, women in the urban area, inequalities in one country. So we need to really ensure that all the layers are addressed. Frank, you've been at the forefront of IT innovation, right? So you'll speak to us about that, and of course, being a pioneer in the industry, you've been keen on connected care across all health settings. We'll speak a bit about that. Dr. Sangu, early stage investor in African tech, focus on African tech, Flutterwave, M-Pharma. This is a rare occasion where an investor and the company are seated next to each other calmly. So we'll get to hear about that as well. And of course, Gregory, you've talked about improved access to medicine by innovating financing, inventory management. Of course, Frank, you'll also chime in because I know that's your field as well. And Professor Sinead, popularly known as the scientist of Ethiopia, a very phenomenal woman, so we'll understand what exactly has been happening in your space as well, and of course get that perspective. Let's jump into the conversation. We'll start off with structural barriers, and Frank, you'll kick us off. You have System 1. Let's speak about System 1. For everyone in the room, System 1 is a system used by health professionals in the UK. Of course, within TPP's vision, if you've ever gone to a hospital and thought, I gave my details 30 years ago, I gave my details 20 years ago, why do I still have to keep giving my details? So basically, a single source of information detailing a patient's contact with health services across their lifetime, right? It looks like what we need to deal with from a structural barriers perspective is very clear, but it isn't, in country and across the world. So we need to understand how different it is addressing patients versus addressing countries with structural barriers around this.
Sure. I don't think the barriers are sometimes as big as we think. Nobody had to convince me to get an iPhone. You know, I saw the iPhone, I saw people using it, and I thought, I would like that. I think give doctors and nurses good technology, give patients good technology, let them access their medical record. And if it's good, they'll want it. If it's not good, you don't deserve to sell it to them or give it to them. I think the answer really to those barriers is to make it good.
Oh, so wait, so we'll come to you in just a sec to just expound on bringing healthcare to a level that most people don't really understand what happens behind the scenes. But Sam, let me come to you because the pandemic really changed a lot of things. You took on Africa Health Holdings in 2020. At that time, people were starting to talk about telemedicine and they were moving into, you know, how to innovate and when they cannot see people. But we still had to prioritize that countries had their own national issues, right? So help us understand priority versus innovation.
Sure, and you know, we've rebranded now as Care Points. For context, we operate in Egypt, Ghana, Nigeria, and Kenya, so we at least have a sense of healthcare policies and operations in those places. But before I dig into this thing about innovation, one comment I do want to make, because I realized that my sister and I looked at each other when you mentioned that COVID in no way was equitably experienced. Yeah. In fact, my father, who's a doctor and did a lot of work on HIV, one day, I was very young and I'll never forget, I was about 6 or 7, and he came home one day and he was literally in tears. And I asked him why, and he said, and I'll never forget, it's not HIV that's killing us, it's poverty. Because the people with wealth were actually able to do fine and afford the medication. It was not the HIV that was killing us, it was the poverty that's killing us. And you see the same thing with COVID. If you run the regression analysis, you find out that a disproportionate amount of people who suffered and who died were the most marginalized people, were the people who are at the bottom of the pyramid. Now, when we talk about innovation and on technology especially, I think we need to be very, and this is one of the things I loved about M-Pharma's model, it's not just tech for the sake of tech. I'll give you an example. Telemedicine is seen as this, we invested in telemedicine, and it's seen in the West as a great democratizer, right? A way to democratize access to healthcare. That works in an environment where there's easy and cheap access to internet. When we piloted it in Ghana, my driver, for example, anytime I send him messages on WhatsApp, he'll come back, I'll say, oh, Sly, did you get the thing? He'll say, what thing? I'll say, oh, but I messaged you. He'll say, oh, Sangu, my data is off. You know, mobile data is expensive. So when you think about it from that perspective, the traditional way of doing telemedicine is not going to work from a standpoint of democratizing access. It has other valuable traits like it's climate smart, it reduces emissions if people don't have to come into the facility, it decongests the facility. But let's not fool ourselves. Telemedicine in the form in which it's practiced is largely going to benefit people like us on this stage who have iPhones. So we had to go back to the drawing board and say, how do we redesign telemedicine in a way that adapts to the idiosyncratic needs of the bottom of the pyramid? And the way we did that was we started creating these tech-enabled microclinics, where we bring the telemedicine inside the microclinics. Because the big problem was actually access to doctors. And you take a place like Wale Wale. Wale Wale in the north of Ghana, there are no doctors there. And the cost to get a doctor from Accra to go all the way to Wale Wale, it will not make sense. But instead, you can put a nurse in a tech-enabled microclinic where you've reduced the cost. A typical clinic would need about 14 people. Instead of a cashier, we put in Flutterwave, right? Integrated it. With medication stuff, you can have M-Pharma deliver the medication for the patients, right? On the on-demand delivery, so now you don't need a pharmacist. And when it's time to see the doctor, there's a big screen, and the doctor is able to now do the teleconsult from Accra. Such an innovation makes sense because it takes the local context, as Right Honorable mentioned, it takes the local context into play and designs it. So in sum, when we talk about tech and we talk about innovation, the first question we need to ask is, what problem is it solving? And we need to start from the problem and not start from the tech.
Fantastic. Wait, before I let you go, before I speak to Gregory, so the kind of work that had to happen between Accra, outside Accra, and then working now to scale that maybe outside to Guinea, let's say Guinea, Benin, you name it, it still has to be done physically. You have to still understand what customizable things you can do outside, right? So it's not a one-size-fits-all. So when we talk about tech, we still have to customize.
Let me tell you something. There was a whole chapter in my doctoral dissertation around the non-tech part of tech. When we had COVID, the government of Ghana issued COVID rules and said no one is allowed to come out. There were only certain categories of people. One of those categories was healthcare. The other category was e-commerce. And I laughed because none of the e-commerce, a lot of people think e-commerce exists in this cloud. If you think about e-commerce, it's all physical, right? You order it online, but after you order it online, someone has to, at M-Pharma, has to physically take your order, go into the warehouse, collect, so if you are not allowing warehouse people right, to go out and work. If you're not allowing the offline nature of e-commerce to operate, you're missing the picture. So sometimes we get seduced into this idea of a digital economy, and we think we can just get up and say digital and build on it. But the digital economy rests on an offline infrastructure that needs to work. We need to have roads that work so you can deliver on last mile. We need to have internet connectivity that's reliable and affordable. We need to have a system that works in general, and then you can build a digital economy on top of it. And you need policy that is not inimical to the creation of a digital economy. For example, the nonsensical e-levy policy in Ghana. Thank you.
We'll get into that as one of those. Right, so we know the kind of chokehold that a lot of governments within the African context have on certain companies, so we'll jump into that. But let me speak to Gregory real quick. Since the money has spoken, let's speak to the person now giving the money back. Let's give the example. You wrote on your LinkedIn that we need to also get off the chokehold, and you're coming to the Commonwealth Business Forum to tell people that they need to, release themselves from the chokehold of aid and humanitarian assistance that also expatriates revenue as well, right? And then someone from Dell replied in your comments and said, I hope the governments resonate with your vision, right? Because that's exactly one of the barriers that we have now. What is practical? And what is happening on, let's say, in management solutions, which you started off as M-Pharma, and what TPP is doing, it's almost in line, but they have a huge resource bucket. If you were to have synergies, what kind of conversation would you have, noting that you wouldn't want humanitarian aid or external assistance?
Well, first and foremost, I'm glad someone is actually reading my LinkedIn posts. Sometimes feel that I'm writing to myself. But, I'll say that's sort of the fight of my life that I have picked. 20 years ago, one of the most amazing global health programs was created called PEPFAR. PEPFAR did so much to help the continent fight the HIV/AIDS epidemic at that time. In the last 20 years, over $100 billion has been spent by PEPFAR and the US government to support the continent to address gaps in HIV/AIDS. Amazing, and I love the US government for doing that. But today, if you go and you ask anyone in the US government, and even if we are honest here, and you ask anyone here, should PEPFAR close the tap? How many of the programs that are running in Africa today, after 20 years, could stand on their feet and be sustainable? And I believe almost 8 out of 10 people will say, no, they can't. Why? Because we have not built sustainability in addressing global health. We've spent decades talking about strengthening health systems in Africa. And much of that has been done through donor-assisted aid. And it's great because of where we came from. But I think the most important question as we look into the future that we need to answer is, 20 years from now, when we look back at the health system in Africa, who would have built it? Would we still be talking about donor aid-assisted health systems, or we'll be talking about a resilient private health sector that has taken the mantle on the continent to actually build the health system as we've seen in the West? And I think that is sort of where we need to look at. And so when I think about that in my own journey at M-Pharma, I arrived in Kigali this morning, and the first thing I did, I went to a multi-pharmacy, one of our pharmacies. We launched in Rwanda a year ago, and in a year's time, built the largest pharmacy chain in the country. And I went to Pharma Best because I think it speaks to what I think the future is. How do we strengthen health systems in Africa? My answer is we need to build profitable healthcare MSME providers in each community who can provide care that is relevant to their community and make money doing that so that they can pay the staff that they employ. Pharma Best, which I visited today, employs 7 people, generates $20,000 a month in revenue. These are health workers where 20 years ago would be looking for a job in the public health system, but they don't need to do that because there's a thriving, local, profitable healthcare SME that can employ them and actually provide the needs of the community. I recently went back to another pharmacy, and before I left, the owner held me aside and said, I just want to say thank you. And I said, why are you thanking me? I mean, you're not doing me a favor. Like, you make money, I make money. If you don't make money, I don't make money. It's just, you know, what we do. It's like, oh no, that's not what I meant. What I meant to thank you for is that our pharmacy has now tripled its revenue. That means I can pay my staff on time. And before I can pay my staff on time, when patients come to the pharmacy, they are happy to treat them. And because they are happy to treat them, more patients come back to the pharmacy. We spend a lot of our time in global health programs focused on the patients. And rarely do we spend time on the people actually providing the care. Actually, one of the biggest problems we face today are lots of doctors, health workers, migrating from the continent to the West. And I don't blame them for doing that. I would want a good salary. I would want to be able to take care of my family. And unless we can actually begin to create profitability, and when we create health programs, actually underwrite sustainability in those health programs, I don't think 20 years from now, we will come back and we'll still talk about strengthening health system in South Africa, and we'll talking about donors, humanitarian aid. I mean, that's all amazing. Philanthropy is great. But I believe that the future of health system must be built on the back of profitable healthcare MSMEs, and that's what MPharma is trying to do.
Fantastic, absolutely fantastic. Now, Professor, we've had 3 sentiments that give proper context. You've said before that it's no accident that the University of Global Health Equity was set up in Rwanda, which now provides a roadmap to equity, which begs the question, what has been happening before, you know, on this road? Were we not on this road before? Maybe just tell us, there's some things that healthcare professionals know about equity around the world that we as consumers of medicine and consumers of healthcare don't really understand or will never understand. Help us understand today.
Sure, thank you. It's too bad that we have little time. So many issues have been raised, including DPM. Chris Fern talked about the local versus global. We heard from so many the deep frustration people have with global aid. So inequity, I think you put it earlier, and we saw a little video. Inequity is embedded within the system, and it's just not a global south and a global north thing. I mean, I have spent the last 35 years in the United States living in Chicago and Detroit, and you see the worst inequities within 25, 30 miles radius of capital cities or within the cities. So, you know, it is what it is, and at the end of the day, it's what Sangusdar talked about. It's poverty and how it manifests, and it's not just about health, but it's the social determinants of health. Who has access to food, who has access to housing, who has access to education. Those are the things that deeply determine. You talked about women in the rural area versus women in the city. Women who have access to education versus not. When I look at my path as an African woman versus the millions of African women who are held behind, it's because they don't have access to education. But coming back to the topic at hand, I think what we saw with COVID was the global mechanisms that we put in place, thinking they were going to focus on equity, they were going to protect marginalized communities, they were going to be inclusive, clearly failed us, right? So with COVID, all those global solidarities went out the door, and nationalism took place, and everybody was scrambling for vaccines, and Africa was left on its own. So even when you have aid, even when you have access to resources, the global supply chain just failed, and we couldn't access the basic commodities like PPE. Our healthcare providers cannot protect themselves. So for me, all of it ties back the local context. What lessons have we taken to tackle inequity? So I have spent the last 2 years in Rwanda, and I do agree with Dr. Fern. Rwanda's ability to lead and to govern and to put the right policies in place has allowed it to put together everything we talk about: technology, innovation, thinking outside of the box, global collaboration, making things work. But the biggest thing that emerged out of this is that health system strengthening, you talked about the vertical programming, right? We build systems for COVID. We build systems for HIV. And absolutely a lot of it is perpetrated by, the money that comes to the continent and many parts of the global south come with strings. So we put an EMR that tracks progress on TB and on malaria, and people are more than their body parts. So when you have good governance and good leadership and good national plan, then you can put a system that really builds a strong primary healthcare system. So when you look at countries that did really well with COVID, they are the ones that have a strong primary healthcare system.
Right.
The health system is made up of components, right? It's the health informatics system, it is the workforce, it is the supply chain, it's the data. So I am all for global solidarity, but I'm also very skeptical that we can't get together and talk about global solidarity without building the capacity of locals and nationals, and frankly, building a robust private sector that can relieve some of the burdens. Governments cannot pay salary of the workforce, and as you talked about, that's why they are migrating. So having a robust private sector that's based on technology, we've seen what we were able to achieve, right? We leapfrogged when telephones started, mobile phones. We went from having no landline to the majority of our population having mobile phones. So we can innovate, but that has to be, the bedrock has to be a very strong national system, local and regional institution, that are being driven by their own context and values and priorities, who can then align with the global community.
Right. Frank, we'll come to you for data, but since we have the Honorable Minister here, and we had what Sangu said, let's talk about government and private investors. Yesterday when we were discussing, one of the biggest issues we said, of course, government needs the money to set up different ministries and of course, resource and the money to do it, and government is stretched out, right? We need private investors. Then you have people in tech that come up and they say, we have this e-solution that will help telemedicine, you name it, all these tech solutions that are coming up. And then what Sangu alluded to was the government now introduces an e-levy, and they charge you to it's basically charging you to set up. So basically what we were saying yesterday was they cut your feet before you can even walk, right? And that's the true nature of most governments now. They're trying to tell you you can set up all this tech and all this that's happening, but they, at the early stage, is where they're cutting you off. So government and private investors still have a huge disconnect. But we need you to please just help us understand how we can speak to governments in a way that they can understand that it's a business, yes, but we need to think more mid to long term, not short term, yeah.
Yeah, no, absolutely. I mean, I think at the end of the day, I'm with Sangu.
If Sangu speaks, by the way, I'm a lot more. Sangu
You're toning it down?
Yeah, I'm toning it down.
Yeah, I think, when I think of the health system, I don't think of it as a public sector and private sector. I think of it as a national health system that has various components. So I am with Sangu. When you have a functional government, what you would have is the right policies, right? We get in trouble when government tries to do everything. So again, if my biases towards Rwanda are not clear, I'll put them out. We have models we could look at. Governments can create enabling environment. Governments can create the right policies, the right infrastructure, right, for businesses to thrive. When that happens, when you have a thriving private sector, it alleviates massive pressure from the government system. Having said that, no one can deliver healthcare at scale like government. It does not mean that the government has to actually provide the services. They can outsource. We have many examples. If you have a chain of pharmacies, the insurance system, can use that to access services. But, oftentimes there is a dichotomy of, oh, no, this is done only with government. There's, as if you're running to different systems in a country. The truth is, at the end of the day, government is accountable for everything because citizens can only hold government accountable. Even for businessmen, the accountability framework comes from government, right? So A functional government is key to have a thriving private sector. And we see now many African countries, Ghana, Rwanda, Senegal, the private sector is thriving, and health historically has been dubbed, again, because of aid and because of dependency, health is considered free. The truth is, health is a human right, and people have a right to health, but somebody has to pay for it. So this notion that health is free makes it completely devoid of prioritization. So governments don't put resources into it. Oftentimes there is data, although most of healthcare is covered by public financing, whenever aid money comes, it displaces government funding. So I think what we need is government to allocate budget, but to figure out a way to work through private sector, through public sector, looking at a comprehensive national health system. And for me, while I don't often sit with the business community, but while I have you here, you may think health is not your business, but if this COVID pandemic has not made it clear that health is everyone's business, right? It is not, even if you're not in the business of providing health care. Health is about everything else. Health is about food security, health is about climate. They're all interconnected. And if you don't have a healthy community, you're not gonna have a healthy workforce. So businesses are gonna be shut down. So I think we all have to look at it that it is our responsibility to have healthy society and functional society. And I think when we look at it, because what happens is instead of focusing prevention, we focus on curative services. So therefore, because you're healthy, until you get very sick, you don't think you need health care.
Perfect, thank you. Yes?
Yeah, look, I'll add quickly on that, you know me, I speak truth to power. We need to stop politicizing healthcare, okay? We need to depoliticize it, and for the sake of God and our babies, governments need to stop the shenanigans in healthcare. And the reason I say that is, if you go and you do something in some of the other sectors, if you go and you worry an oil and gas company or whatever it is, maybe you should worry them for the climate, people are not dying. But when you start to introduce some of the silly politics into our healthcare system, the outcome, and we see it, Greg and I see it every day in our business, babies die. When you have an airport and you have a $5 antigen test and you're charging $150, right? When you have situations where money is allocated to build healthcare infrastructure, and you have a UGMC, for example, and it's not really operational because of silly politics, babies die. And so part of why I'm so angry about it is, take the politics elsewhere. But when it comes to the health and the lives of our children and our babies, for crying out loud, let us depoliticize that system and let's allow it to work. All we want to do is to deliver care. Leave us alone and let us deliver that care. Thank you.
The only transition from Sangu to the next panelist is applause, so there's that. Now, final point before we get the audience, because I know there's a lot of questions from you. Another thing that came out yesterday was, when we come to the airport, for example, there's a form you fill, you write your name, your email, and most of us say, governments are collecting our data. But the nature is there's so much data and in different forms, right? And so one of the things that was mentioned was, most of the time it takes 6 months to a year, over a year, to know what to do with this data, to dig this data up, to mine it, to even peruse through it and see what it's useful for, right? So, given that context, where it's year 3 of the pandemic, we need to use this data to anticipate anything else that might come. Just give us insight on how we can prepare while still fighting, preparing while fighting, collecting while fighting, knowing how long it takes to bring out useful data into practice. Speak to us, Frank. Yeah.
Yeah, well, we did a lot of work on this, and I think especially when you don't, sorry, COVID has been a terrible thing that's happened across the planet, as we all know, and you can't not think about all the people who've suffered because of it. But it really is no difference to swine flu or the common cold, and isn't really that hard to put measures in. We did a lot of AI to analyze the doctor's notes, to analyze what was going on there. And all you need to do is start tracking changes. Now, if we had done that in the UK, we'd have spotted it round about the 3rd of January. Instead, 22nd of March, we started to take it seriously. So all you need to do across the population, and it's actually much quicker than you think. I mean, we were up and running doing COVID research within a week, once we were given the go-ahead to do it. So it can be done. And the other thing is, if we share the knowledge around the Commonwealth, you're going to do it even quicker. And we're happy to share our knowledge, you know. And that's the secret. Don't go trying to do it all in your own country by yourself. Look at the country next door, find out how they've got on. And I know it's not the question, but we mentioned poverty. Poverty, poverty, poverty. We saw in the UK, we could see certain ethnic groups were not doing well with COVID. And there seemed to be immigrants, like my parents were immigrants to England from Ireland, and the more we looked at it, it had nothing to do with immigration or ethnicity. It was just sheer poverty. And in an NHS in the country where I come from, where it's free at the point of care, it gave us some food for thought. And it seemed to be that these people were working so hard, they didn't even have time to access free healthcare. And I think that needs to be something, just replying to your point there, something we need to think about.
Can I add an example?
Yeah, please.
Yeah. You know, there's no misgiving that the primary mode through which Africans get healthcare is through self-medication. Right? We treat ourselves because it's affordable, right? You know, you don't want to spend money going to a hospital to pay a doctor's fee. You know, if you can quickly treat yourself, Dr. We were the original Dr. Google before there was Dr. Google, right? And so the pharmacy has become this base of primary care, even if we don't consider them to be primary care channels, right? So I've always said that actually the most important health data that sits in most African countries that is not being tapped into is pharmacy-based data. And most governments have not integrated their local pharmacies into the national health data reporting systems. So for example, at the beginning of the pandemic, we built an analytics tool for the government of Ghana. We picked 300 drugs that people would use to treat symptoms of COVID. Because most cases in Africa were asymptomatic. Most people, we had few testing per capita. And we said, if you probably see a rise in people buying these drugs beyond the pre-COVID dispensation rate, you probably should go to those communities to do community-based testing. As to whether the government used it or not, I don't know. But we could always predict a wave of COVID 3 weeks before it happened. Because all I had to do was look at my consumption trends for just those 300 drugs.
Absolutely.
And I could always tell that there was another wave of COVID happening. We just saw that just last week in Ghana, where we're experiencing the 5th wave. And we saw that weeks before that happened, because all of a sudden, I saw a significant jump in people buying medicines for respiratory conditions, cough, flu. Right? So the data is there, the data is in the communities. We just need to reimagine how people actually seek care, invest in those channels through which people seek care, and then the data will be there. People walk into pharmacies all the time, and they're just giving us this data.
Fantastic, absolutely fantastic. Let's give a warm round of applause for the first set of communication. Thank you very much to the panelists. Please, for the interest of time, if you could just raise your hand and we'll have a microphone come to you. Please, let's get the questions flowing as much as possible. No? Perfect. Oh, looks like we're out of time. Imagine that. But I do understand that we'll definitely have a lot of people interacting with you after this. And we need to hear from very specific points of view about what the future looks like for global health equity, right? So please, if you can, please allow people to mingle immediately after this. Before you leave, we'd like to, as we did yesterday, just understand in one sentence, if you were to say what the future of health is, let's say within Commonwealth countries or around the world, what is one thing that you would want us to reimagine? That's it, in one sentence, as the future of healthcare. Sangu?
Well, the future is African.
Mm-hmm.
So the future of healthcare will also be African.
Fantastic. There we go.
Well, public health does not mean government run, which means that the future would actually be built on the back of a thriving private sector, relieving pressure from government-run health facilities.
Perfect. Please.
I don't think we have any option, but self-reliance means localization, especially when it comes to commodities.
All right. Frank.
Artificial intelligence.
You know why that is a fantastic segue? Because the next person that we're going to hear from is speaking about artificial intelligence. So I don't know whether that was that scripted? Not scripted at all. Thank you very much. Maybe as I call the other person on stage to deliver the speech on that side of the presentation, we've heard of artificial intelligence on one side, we've heard of responsible investment. Rarely do we hear the two together. In responsible AI, right? So let's hear from Catherine Toure, Regional Director for Eastern and Southern Africa, IDRC Canada, as we get off the stage. Thank you very much.
Artificial intelligence, or AI, when implemented using people-centered and rights-based approaches, what is called responsible AI, can improve public health outcomes. I would like to share a few stories of how Africans across the continent are shaping the area of AI for health. I join you from Nairobi, where I work with a dynamic team of about 30 people from the International Development Research Center, or IDRC. My name is Catherine Toure, and I am pleased to be part of this session on equitable healthcare. IDRC is an organization of the Canadian government and has been supporting for over 50 years participatory research and innovation led by diverse teams in the Global South. At IDRC, we do not fetishize intelligence in general or AI specifically. We can talk later more about what I mean by that. Rather, we see the potential of AI and the need to support Southern researchers to make it applicable in their communities. It is common knowledge that bias can be embedded in big data and AI algorithms. AI, to be worthwhile and beneficial in health, must be informed by data sets that are inclusive and representative of all groups of people that they are meant to serve. To support the emergent field of responsible AI in Africa, IDRC is investing with others in AI for Development Africa. Researchers work with governments and communities to harness the potential of AI, and entrepreneurs bring their AI-driven innovations to market. Through AI for Development Africa, AI innovation hubs have been set up across the continent. For example, at Université Virtuelle du Burkina Faso, University of Lagos in Nigeria, and Dodoma University in Tanzania. The hub at the Infectious Disease Institute in Kampala, Uganda, focuses on reproductive and maternal health. Partners from academia, government, civil society, and the private sector work to ensure diverse data sets paying attention to factors such as ethnicity, ability, and socioeconomic status. Another program, Global South AI for COVID, supports COVID-19 response and recovery in low and middle-income countries. The Global South teams develop and scale responsible AI solutions, meaning ones that are inclusive, rights-based, ethical, and sustainable. For example, researchers in South Africa rolled out a COVID-19 dashboard that predicts epidemic trends and informs decision-making in real time. In November 2021, their modeling informed provincial and national guidelines to limit the spread of the Omicron variant in the country. Similarly, researchers in Eswatini, Namibia, Botswana, Zimbabwe, Mozambique, and Nigeria are creating AI applications to inform government and combat misinformation with reliable data. Another innovative project is led by Dr. Aurore Nishimwe of the University of Rwanda. If she happens to be in the room, I invite her to just stand up and wave, but it's possible she wasn't able to make it today. Her team is consolidating fragmented data from clinics, hospitals, and testing sites to understand and predict the impact of COVID-19, similarly in line with what our colleague from Pharma just mentioned. The approach can later be scaled to include data on other infectious diseases, such as influenza. The team is leveraging machine learning, traditional mathematical modeling, and statistical methods to predict the impact of public health measures on the pandemic's evolution, on the economy, and importantly, on mental health. Finally, IDRC is launching a new initiative in Africa, Asia, and Latin America called AI for Global Health. We are investing 15 million Canadian dollars in research on responsible AI applications in two areas, epidemic and pandemic preparedness and response, and in the area of responsive reproductive and maternal health services. Recognizing, as we've been discussing today at this session and in the whole Commonwealth Business Forum, the role of the private sector, this new initiative includes research on scaling and commercialization pathways for AI applications in the two focus areas. We are working with social impact investors to support healthcare startups to make healthcare more accessible through responsible AI. For example, Dawa Health in Zambia is using AI to power a digital health platform that supports maternal health consultations. In this brief contribution, I hope I have provided a sense of how Global South organizations and networks, especially in Africa, are working in linked up ways to learn from each other and build a foundation for AI to extend the reach of healthcare in culturally relevant ways across the Commonwealth and beyond. I look forward to connecting with Business Forum participants to advance this innovative and transformative work, particularly on the continent. Thank you very much.
Thank you very much for that. We'll also be engaging a bit more after the session. Let's jump straight into it. For this one, we'll do one round of questions and then we'll let the audience ask the questions. The next chat is for 30 minutes on innovating for vaccine equity. Let me call the people on stage. Robert Nelson is the chairman for Resilience Biotech from the US. We have Holm Keller, who's executive chairman and CEO for Canap Germany. Kindly. And Tim Runeke, who's the commercial director and CEO, Commercial Director of Crown Agents UK. Please. Thank you very much for joining us. Now, of course, it's a painful conversation whenever we discuss vaccines, particularly from an African context, emerging markets, you name it. It's very painful because, as we've discussed, there was a lot of inequity when the pandemic hit, and what we saw with logistics, things that could have been dealt with. We've seen people now say, you know, we ordered a batch of vaccines, they were transported somewhere else. So that conversation has also, just like the previous one, a lot of layers. So availability of vaccines for everyone here, it started as a logistics issue, moved into a money issue, moved into a moral issue, moved back into a logistics issue, and then it became all of it together, right? Until we had 3 billion doses of these vaccines manufactured, you know, shipped to 180 countries in just 1 year, but it all looked good on paper. The reality of it on ground was very different from what we know, right? Let's start off, of course, with Robert. We have a serious illusion, disillusion of what global health care actually looks like. We have most of the people that invest in Africa have an idea of what we should be doing with our healthcare system, while we've seen close to a decade where people can't even decide what the name of the healthcare system should be, you know? But they're trying to decide what the future of healthcare in Africa is. Just help us now, just reconcile from a very rational point of view, remove the politics aside, what we think has gone wrong in terms of making that connection to everyone else, regardless of the demographic.
Well, I'm kind of a newcomer to the space, so I look at ways of kind of stepping back and looking at the system and figuring out why it's broken. And I think it's a system where, if you look at infectious disease, for instance, which I see as kind of one of the main problems, we're trying to adapt technology to the system instead of asking what technologies would solve the problems of the system. And so if you think about even COVID, we're trying to take new revolutions, like mRNA as an example, to solve problems, which we should. But there's cold chains, there's last miles, there's complexities of distribution. And what I'm really interested in is saying what the system should look like, right? What the system should look like is that you don't have to encounter patients very much because you have good immunology. What the system should look like is that you can access without cold chains, without complexity, patients in a way that reduces kind of vaccine hesitancy. And what the West can bring to that discussion is actually thinking about those problems with Africa to identify what should the ultimate system look like. You should be able to manufacture things locally or on continent. You should have control of your own systems and destinies and manufacturing. And what is interesting about COVID is that nobody really understood in the West, really understood infectious disease before it hit them really hard. And Africa has been understanding this for a long time. And so people are paying attention, and even, you know, France was begging for a vaccine, right? Even though Africa was the last on the list to some degree, all of the countries in the world kind of understood the idea that they don't have this and they need it. So there's kind of an agreement that the system is broken, that the supply chain's broken, that we haven't invested in manufacturing, and that we haven't invested in infectious disease. And if you think about what the semiconductor industry did, right? They invested in manufacturing and made things better, faster, cheaper, more automated. That's what we're going to do in biotech. And that will make it more accessible for Africa. If you think about what the cloud did for computing, systematization will do for access and control, for African kind of control of your own destiny. So I kind of think technology is going to solve a lot of the problems all the way to the last mile. But we need to ask the questions like, what is the system that we appreciate? We shouldn't be chasing viruses all the time, so we have to encounter people every 6 months. That's not going to work, especially in Africa. It doesn't work in the US. We should have systems where we have to encounter, and technology where we encounter people infrequently to have great immune responses that can be, administered without a bunch of complexity.
Right, and if you need the insight on that, of course, we have the gentleman speaking from Ghana who are doing that really well at the moment. Let's speak to you because there's a groundbreaking with the mRNA happening, and you'll tell us a bit more about that. But so people have argued it's year 3 of the pandemic, as we were saying. You mentioned that Africa was last on the list, but it doesn't negate the fact that there's now a realization that we can set up a facility to prevent future pandemics, right? So speak to us about, when people think about vaccine manufacturing, it just looks like a company can come, have a partnership, set up, and execute, but that's not the case. It takes a lot more. Speak to us about that.
Yeah, thank you very much. Actually, I think this is a chicken and egg issue.
Yeah.
It's something very simple. The world had no interest, and most African countries, until the pandemic, had no interest to have vaccine manufacturing.
Say that again?
I say it again. The world had no interest, and most African countries had no interest to have vaccine manufacturing prior to the pandemic. And the reason was that we all jointly invested in massive, lowest cost possible capacity in India and in single points in the world. The pandemic has changed that perception. And now it's indeed chicken and egg. Somebody has to put a factory first, and this is what will happen in Rwanda with BioNTech tomorrow. This factory will bring suppliers.
Let's have a round of applause, because the groundbreaking for mRNA is tomorrow, and that's a big deal, also being held here within the region.
We do look forward, yeah. So what this will actually do, ladies and gentlemen, it will bring suppliers, because BioNTech can't do this alone. There's lots of companies coming along, and these suppliers will allow other companies to be established and to be operating. There is a workforce empowerment program, because we expect Africans to work in this factory and not Europeans, and this will happen as quickly as humanly possible, taking into account that in Europe or in the US also no workforce existing in the moment. So it's a normal problem to tackle, and we'll tackle it in Africa, for Africa, the normal way. And the third element is it will help build regulatory capacity, both at the NIA, so the national regulatory level, but also at the upcoming Africa Medical Agency. It will change the way how WHO will need to look at pre-qualification. And all these things together could be started at any of those 4 points.
Africa or other emerging markets. And we need to also trust that you've done enough data, enough research to inform your decision. And we need to trust that it's Africans, for example, if it's in Africa, leading the conversation. Speak to us about trust from your perspective.
Yes, thank you. Well, trust is hugely important. Whereas my colleagues on the panel speak at this from a health perspective, our experience at Crown Agents has mainly been in supply chain. So delivering vaccines, we delivered millions of doses to some of the hardest to reach places across the globe and remotest. And also worked on behalf of the British government to redistribute excess vaccine doses to countries that currently have low vaccine take-up and really need them. And in all cases, we've seen how important trust is. And where trust, as far as citizens are concerned, in public health programs derives from, is effectively completely connected and interrelated with the trust they feel in their government. People need to trust their government to trust the vaccine. And we found this as one of the key causes of vaccine hesitancy. And we've worked with governments worldwide to try and improve the messaging and integrate messaging across departments in terms of community outreach to some good effect. But of course, we've also got to look at what's happened in the pandemic context. And as we move into this, of course, it's not a post-pandemic world, but it's where COVID has become endemic, and as much as possible, countries are trying to build back life as normal. And so we've moved from vaccine hesitancy as a driver of trust or lack of trust to more of vaccine fatigue, especially in rural areas, especially in sub-Saharan Africa, where many families, where many communities have a whole range of health problems and health challenges to deal with, and not just COVID, I mean malaria and so on. And also, taking the vaccine would perhaps really impact on their day-to-day livelihood. We had, I think it was from Gregory, talking about the kind of barriers in rural communities, and we've heard stories of parents having to walk for a whole day just to get to their nearest vaccine centre and a whole day back again. So we're now addressing sort of vaccine fatigue, and our recommendation to deal with the trust issue beyond making sure the messaging is right, is to ensure that COVID-19 vaccination is really integrated in routine immunisation programmes, and we feel that will go a long way to dealing with that.
Fantastic. Okay. So early onset, when we're doing the other immunization, we factor that in as well. COVID. Fantastic. All right. Let's get the questions from the audience so that we don't block anyone out. There was a question from from there. If you could just raise your hands. Is there a microphone? Oh. There we go.
Good afternoon, everybody. My name is Cletus Chibuko. I'm from Nigeria. I work for a company called Itcell Limited. We're into fortification. I've heard all that was said about healthcare in Africa. But I think that we need to look at micronutrient deficiency, because we found out that micronutrient deficiency is also one of the problems we have in Africa. Eating food alone is not enough. If you don't have the basic vitamins and minerals in the food you eat, you still have healthcare challenges. Immunity is involved. So I will also expect the Business Forum to look at fortification across Africa. I think it will also help us address our health challenges. Thank you.
Perfect. I know the question veers off of topic a bit because we're discussing innovating for vaccine equity, but we can still talk about it, right? So we'll have that question. But please, let's try to focus the questions on the vaccine equity conversation.
My name is June Francis, and I just wondered if I could ask a question that follows up on two things. One is the issue of trust. So I live in Canada, I'm Jamaican heritage, and one of the things we had in Canada initially was enormous lack of trust among some subpopulations that have been, of course, historically rooted. These are the indigenous and black community in particular, where there's been a long history around our bodies being used, of course, for experimentation. And so tremendous lack of trust, and it occurred across the Caribbean as well, where there was a lot of misinformation, but also there was fertile ground, because the sense was that the developed world has never paid attention to us, and suddenly anytime they're sending something our way, it became something to be suspicious of. And so trust in government is one thing, but I don't hear anybody addressing trust in the historical medical community and the historical ways in which many medical issues that relate to African people, black people of African descent, have not been addressed. So there is a general lack of trust in the international community's medical programs. And I'm wondering, what is there in your, what would be your response around increasing trust not only in governments and programs, but in the medical community's ability to really develop medical interventions that address us? Because I think that was a major problem across the entire world.
Perfect. Thank you. Thank you very much. So we have, those are 2 questions. I'll circle back to those. Let's have one more so we can address 3 at a go. There's one here. Oh, right.
Good afternoon. My name is kIGALI. I'm from Kenya. And congratulations, that's been a very interesting conversation, and particularly interested in the vaccine manufacturing facility. And we have had a conversation about trust, and I'm not going to repeat the question the lady just asked. However, have we given consideration in bringing the manufacturing capacity onto the continent? Where have we worked in so that even though there was conversation about the process being led by African people or Asian people or wherever the facilities are going to be, but focusing on the one that's being groundbreaking tomorrow, I think about East Africa and the amount of capacity and tech. You know, East Africa is a tech hub for the continent. And I don't know how much of the AI that is being used in the medical sector and in going forward, thinking about producing vaccines on the continent in East Africa, how much of that are you relying on the knowledge that's available locally so that the AI looks more like the people that are in the continent? Because we are aware about, and it goes back to trust, the biases that have been inbuilt in AI. Thank you.
Right. I feel like it's a bit of a mix. So let's start off with the issue on...
2 questions interrelate very well. And there is the issue in the room, the minimal data that has been collected in African patients compared to in Caucasian patients. So in the end, to reach vaccine equity, we also need to massively start conducting trials in Africa. This is to some degree happening, but not to the degree necessary. Certainly not in oncology and in some of those disease domains where in the moment research is focusing. And unless this will happen in parallel, we will not be able to get to vaccine equity and we will not see trust. And by the way, the distrust is justified because we do not have the same amount of data and often not the relevant data points. And we make assumptions that in Caucasian people and in African people, things should work the same, which in many cases, on many instances we know is simply not the case. So I can only applaud to these 2 questions, and you will see us in full support of truly globalizing and Africanizing these efforts, which has to come on the flip side of local manufacturing.
Just maybe just a question to clarify for what was being asked. So when you set up the facility here, there are already people who have extensive data and insight into what issues are faced, who the trials could be conducted on. Would you work with people that already have existing companies, or would you come and set everything up yourself?
So the groundbreaking tomorrow is on a factory, BioNTech from Germany, a German company, is building, investing and where the plan is that the majority ownership will move to Rwanda very soon. So this is a classical tech transfer case. In this tech transfer case, built in is a staff qualification and training model with the aim to have African scientists operate this plant. And what might be more important, and you'll hear some of this in the Malaria Summit tomorrow, we are expecting the first vaccine to be manufactured there to be on malaria. So hopefully something that can contribute to eradication on an eradication TPP as a preventive malaria vaccine for both small children and adults. So whatever this factory will manufacture, there is a dedication of the company to make sure it can only be used in patients in Africa. So it will only be exported out of Rwanda, if at all, to member states of the African Union. And what we do look forward is a rich set of cooperations with the leading African research and development organizations on all of these projects.
Perfect.
I actually think that's super interesting, you know, to create the beginnings of an infrastructure, right? So that you actually, the sign of success in Africa will be when you have vaccine companies competing for the business, right? That there's actually multiple approaches, multiple entities, and this is an unbelievably important first step. And then I think you will see actually this kind of local partnership model that allows people to take control, to have more clinical development and really competition. And I wouldn't, you know, to me, the ultimate sign of success is Africa exporting vaccines to the West after it's taken care of its own citizens, right? So I actually think that that it's entirely possible that you could have a decentralized manufacturing throughout Africa where there's enough capacity to address
bring it to
endemic
the US?
diseases and potentially get scale to dominate in some other areas. So I wouldn't define it only as you know, that level of success. The ultimate success to me is when you have a competing infrastructure that's addressing endemic diseases, but also can address even pandemic or other types of diseases outside Africa.
Right, so you wouldn't subject us to extreme certification and extreme standards of quality before you take an African vaccine?
No, I think that the quality as what's happening now, as you systematize like the semiconductor industry.
Everything is standard,
right?
yeah.
A vaccine made in Rwanda is going to be the same as a vaccine made in Berlin or in San Francisco. And that's what we haven't invested in before, is this kind of systematization. The whole industry has been working on 50 or 100-year-old technology. mRNA is like version 2. Version 3 is systematizing all of it to be more accessible. When it's more accessible, then it really is more accessible within Africa, but it doesn't mean that Africa shouldn't aspire to be more than just a supplier to itself. It should aspire to be a supplier to the world, in my view.
Fantastic, as we've done with other sectors. Fantastic. Please, you wanted to say something?
Yeah, George, do you mind if I come back to the lady's question from Canada?
Please, yeah.
Which was a very excellent question, and I can only focus on part of it, but I picked up on something which really resonated with me. I mean, we talked about trust in governments, but you also talked about the health communities and how important it is, I guess, a clinic or health facility level to really raise that trust. And one of the barriers we found to that is there's a lack of correct incentivization and training for staff and nurses and those responsible for giving the vaccine dose at a clinic and health facility level. And perhaps I could ask a rhetorical question to the audience and indeed my fellow panelists. What percentage of permanent healthcare staff across the continent of Africa, do you think are paid a regular salary? Any guesses in the mix? Right, well, I tell you, it's just 14%. So what's that? 1 in 8 health facility workers receive any kind of reliable salary. And we've seen it in a lot of our projects at Crown Agents. For example, we're responsible for inspecting vaccine refrigerators and going right to the last mile to rural communities and sort of engaging in the training of nurses and healthcare workers on using this equipment. And without fail, when we return a few months later, a lot of the staff have left. You know, we'll say, where's the manager that we met last time? And they've left, they've moved on. So that's a long way around of saying, I think the answer to build trust at the community level and rely on healthcare workers in the most kind of rural areas is to ensure they're correctly incentivized. And I know Gavi have done a study on this in Nigeria, where they paid staff, I think, 500 naira. My colleagues from Nigeria will be able to tell me correctly, but I think that's about $1 for every child vaccinated going through the immunization program, and the percentage uplift was hugely significant. So I think around that trust at the community level, we really have to rely on governments to support their healthcare workers more. Thank you.